Improving selection and utilization of continuous glucose monitors for people with diabetes. Clinicians who participate in this activity will improve their ability to develop new communication strategies to help their patients with diabetes optimize use of their CGM technology to improve their glycemic control. Select patients with diabetes who will benefit from the use of the CGM technology. And manage patients with diabetes and prevent severe acute complications such as hypoglycemia and diabetic ketoacidosis. Faculty for this activity includes Dr. Elise Brett, Associate Clinical Professor in the Division of Endocrinology, Diabetes, and Bone Disease at the Icahn School of Medicine at Mount Sinai in New York City, and Dr. Kimberly Wen, an internal medicine physician with Kaiser Permanente in La Mesa, California. Neither Dr. Brett nor Dr. Wen have any financial relationships to disclose.
Hello, I'm Dr. Elise Brett, Associate Clinical Professor in the Division of Endocrinology, Diabetes, and Bone Disease at the Icahn School of Medicine at Mount Sinai in New York City. Hemoglobin A1C is one of the ways in which we assess glycemic control in people with diabetes. For most people with diabetes, an A1C of less than 7% indicates good control and is adequate to prevent microvascular complications. However, A1C targets need to be individualized, and more stringent targets of less than 6.5% may be indicated in some people, such as those with low risk for hypoglycemia and long life expectancy, whereas less stringent targets up to 8% may be indicated for some people, such as those at high risk for hypoglycemia or those with already established vascular complications. But hemoglobin A1C does not tell the whole story when it comes to glycemic control. The graphs on the right show glucose levels in two patients, both with a hemoglobin A1C of 8%, but subject 1 has high glycemic variability and subject 2 below has low glycemic variability. High glycemic excursions have been linked to micro and macular vascular complications. Furthermore, A1C can be unreliable in conditions such as anemia, hemoglobinopathy, renal disease, liver disease, after a recent blood transfusion, and certain drugs can affect an A1C result. In addition, since A1C represents the past 3-month average blood glucose, it will not reflect short-term changes in glycemic control. Therefore, continuous glucose monitors can be helpful in providing additional information about glycemic control. CGMs use a sensor inserted through the skin into the interstitial fluid. The sensor is in proximity to a transmitter, which then sends data to a receiver via Bluetooth, and the patient reads the glucose levels on a receiver. Glucose is transferred from the capillary endothelium to the interstitial fluid, so there can be a lag time as compared with capillary glucose, and this lag time can range from 5 to 15 minutes. So it's important to note and explain to patients that the CGM reading is not expected to be exactly the same as the fingerstick glucose. It's not that it's unreliable, it's just not exactly the same. There are different types of CGMs. RealTime CGMs read glucose levels continuously, typically every 5 minutes, and display data on a receiver. Intermittently scanned CGMs, also known as flash, rely on the user to actively scan the glucose to display a reading. Professional CGMs are placed by the healthcare professional and worn for between 3 days and 2 weeks. The results are not visible to the user while the device is in place, and the device is removed in the office and readings are downloaded and reviewed with the patient during a follow-up visit. Sensor-augmented pump CGMs are continuous CGMs that communicate with insulin pumps and have the ability to augment basal insulin delivery as glucose is rising, or suspend insulin delivery if glucose is low or predicted to go low in the next 30 minutes. Here are some images of currently available devices. Note the images are not designed to scale. The two on the far left are intermittently scanned CGMs, which are worn on the arm. The two in the middle are continuous and sensor-augmented pump CGMs, which are worn on the abdomen. The one on the far right is a continuous CGM that uses a sensor implanted under the skin of the arm, which remains in place for 90 days. Each of these devices, in addition to displaying glucose readings, has arrows that show the direction of glucose trends so that the user can act in real time to prevent a severe high or low glucose. When we look at CGM reports, we talk about time in range, which is now validated as an important glucose measure. The usual goal is to be in target range, 70 to 180 milligrams per deciliter, more than 70% of the time, with less than 4% of time spent below range, under 70, and less than 25% of the time spent above range. However, just like A1C, the target glucose range varies based on the person with diabetes. For example, for older high-risk patients, the target time in range of 70 to 180 is greater than 50%. And for pregnancy, the target range tightens up with the high end at less than 140 milligrams per deciliter. This study shows the relationship between hemoglobin A1C and time in range. As you see, the target of 70% time in range correlates with a hemoglobin A1C of 6.7%, the hemoglobin A1C target. Time in range may be a preferred metric for diabetes complications. This slide shows data from a large study of over 6,000 patients with type 2 diabetes monitored with CGM, or a median follow-up of 6.9 years, over which time there were 838 deaths. Time in range was inversely associated with long-term risks of both all-cause mortality and cardiovascular mortality. This slide shows data from the GOLD study, a multicenter study of patients with type 1 diabetes on multiple daily injections, comparing use of real-time CGM versus finger sticks. It shows data from 2 different time periods, and in each segment, the time spent in hypoglycemia was reduced with the use of CGM versus conventional therapy. This was true for both daytime and nocturnal hypoglycemia. And here's data from another study, this one in patients with type 2 diabetes on intensive insulin therapy using intermittently scanned CGM versus finger sticks. The graph shows that time in hypoglycemia, both mild and severe, began to decrease as soon as participants were able to utilize the sensor glucose readings for self-management. Again, this was true for both daytime and nocturnal hypoglycemia. And here was a multicenter crossover trial of patients with type 1 diabetes already using an insulin pump with integrated sensors added to their treatment. The study shows that when they had the sensor on, the A1C improved, and when the sensor was off during a washout period, the A1C increased again, and it went back down quickly with the sensor on. And here's data from a large-scale study looking at health-related quality of life measures in sensor-augmented pump therapy versus multiple daily injections with fingerstick monitoring. The researchers surveyed adults, children, and caregivers on multiple parameters. Results suggested that sensor-augmented pump therapy may have positive effects on diabetes treatment satisfaction compared with conventional insulin therapy. This was especially true for convenience, efficacy, and overall preference. This slide shows a subgroup analysis from the DIAMOND study, a multicenter trial of patients with type 1 diabetes on multiple daily injections randomized to real-time CGM versus finger sticks followed for 24 weeks. The data on the right shows participants with lower baseline time in range had a greater increased time in range at follow-up. The mean increased time in range was greater among all users of real-time CGM for all levels of baseline time in range compared with fingerstick monitoring. The IMPACT trial used flash glucose monitoring in patients with type 1 diabetes on multiple daily injections, this time with a well-controlled type 1 diabetes, baseline A1C of less than 7.5%, and showed less hypoglycemia and improved treatment satisfaction with CGM compared with fingerstick monitoring. Now let's talk for a minute about postprandial glucose. Data suggests that greater glycemic variability may be associated with lower quality of life and negative moods. Furthermore, glucose spikes may be an important determinant of cardiovascular disease, perhaps even more than hemoglobin A1C. Postprandial glucose peaks 30 to 60 minutes after a meal when patients do not typically perform finger sticks. Continuous glucose monitors can help patients understand how different foods, exercise, and medications affect postprandial glucose and can use this data to adjust medication timing and dosages. This slide shows data from a meta-analysis of 18 randomized controlled trials lasting 12 to 36 weeks and involving 2,461 patients. Compared with the usual care, CGM use was associated with increased time in range and lower time above range and lower time below range. This was true independent of diabetes type and method of insulin delivery. Overall, fingerstick monitoring certainly has its limitations. Fingersticks are painful, they give only a point-in-time measurement, they depend on the patient to decide to monitor, and certainly may fail to detect nocturnal and asymptomatic hypoglycemia. Continuous glucose monitors require the patient to be willing to wear the devices. They're more expensive, they may depend on insurance coverage. They've been most studied and perhaps most useful in patients on basal bolus insulin, but can be utilized in almost any patient with diabetes who needs to improve time and range, and are very helpful in anyone at risk for hypoglycemia, including those on sulfonylureas as well as those on insulin. They can provide excellent feedback regarding the impact of diet and exercise on blood glucose. So to summarize, CGMs measure interstitial fluid glucose continuously or intermittently scanned. The data provides information on glycemic variability beyond hemoglobin A1C. They've been shown to reduce hemoglobin A1C and improve time in range. They are useful for in-office patient education as well as real-time daily management. They can help show how glucose rises after certain foods or how it is affected by exercise. They are useful for preventing nocturnal hypoglycemia and for patients with hypoglycemia unawareness. And they are especially useful for insulin dosing and hypoglycemia prevention when integrated with insulin pumps. So please join us as we meet Susan, Maria, and Barry and discuss how their use of CGMs is helping them to manage their diabetes. Now, let's meet Susan. Hi, Susan.
Hi, Dr. Brett.
Nice to see you.
Nice to see you as well.
So tell us, Susan, how old are you?
I'm 64, but I try not to look my age.
Don't we all? And tell us, how long have you had diabetes and what type of diabetes do you have?
I've had type 2 diabetes for 30 years.
And you've been coming to my practice for about 20 years now, correct?
Yes, we know each other a long time, Dr. Brett.
You've been doing well recently. Your diabetes has gotten under good control and you've lost weight.
Absolutely. I've been watching my diet more carefully now, especially when I'm traveling for work, and I've been exercising more.
So when you were first diagnosed with diabetes, we began treating you with metformin. You've used several different oral agents over the years, and you're still taking metformin, but also empagliflozin along with dulaglutide, as well as insulin.
That's right.
I looked back, and I think you've required at least some insulin for about 10 years now.
I wish I didn't have to take insulin, but it really helped control my blood sugar.
I know. I understand that taking insulin injections is difficult, but for a long time we couldn't get your A1C down below 8, and now it's been consistently at goal for the past few years. In fact, your last A1C was 6.0%, down from 6.7% 6 months ago.
That last one was the best in many years.
Now, before we started with the CGM, how often were you testing your blood sugar with finger sticks?
Not often. I hate pricking. I tested sometimes in the morning before work and when I had time. My morning readings were always good, around 80 or 90.
What about during the rest of the day? Did you test before you took your insulin injections?
No, I just gave myself the shot.
We discussed that it would be helpful for us in managing your diabetes to know what's going on with your glucose throughout the day. Current guidelines from the American Diabetes Association suggest that we can improve disease management if we can monitor your time in range. This helps us better understand what is happening than just looking at a snapshot in time with a fingerstick reading. I know you're busy, and you mentioned you travel a lot for work. Tell us, what kind of work do you do?
I'm a security consultant for the NSA. I'm away from home at least 1 week each month.
I understand. In order to give us more information about your glucose control, you agreed to try a continuous glucose monitor a few months ago. And what happened when you tried the CGM?
Actually, the first time I tried it, it fell off my arm after the first day, and I didn't bother to get a new one.
I know it can be an adjustment, but I suggested a few times that you try it again. You finally agreed recently, and then what happened?
I called you in a panic the next day.
What caused your concern?
It kept me awake all night. Those alarms, I told you, I really didn't want to use that thing.
What was happening specifically?
It said that my glucose was low all night. I had to keep drinking juice to bring it up. I could barely get to work the next day.
Were you having any symptoms?
No.
Okay, so let's review your blood glucose tracing. There are multiple glucose levels in the 60s from 1 to 4 a.m.
I don't know why my glucose would suddenly be low.
Actually, I don't think it was suddenly going low. I think it had been frequently low and it was going unrecognized. That's potentially dangerous because if it becomes very low, you could become confused or lose consciousness and might be unable to treat yourself. Without the continuous glucose monitor, we would never have known.
Well, that's very scary because I live alone.
It is. So you were taking insulin glargine at bedtime, and we cut down the dose from 32 units to 24 units. Did that stop the nighttime lows?
Yes, I was able to sleep the night without the alarms going off.
And what's your current treatment regimen?
I take the insulin glargine injection at bedtime, 24 units, and I take the insulin aspart injection, 10 units at each meal.
If you continue to use the CGM, we can also vary your pre-meal doses of insulin based on your glucose readings. This should allow us to reduce your overall insulin doses while maintaining your glucose control and decrease the risk for a hypoglycemic reaction during the day.
Well, then I'm all in.
Now, let's meet Maria.
Hi.
Welcome, Maria. Nice to see you.
Likewise.
Tell us a little about your history. What type of diabetes do you have, and when were you diagnosed?
I've had type 1 diabetes since I was 9 years old.
And how old are you now?
I'm 26.
So you've been living with diabetes for 17 years.
Yes. When I was a kid, my parents used to give me the shots, but then once I was a teenager, I learned to manage it on my own.
As I recall, for many years you were giving yourself multiple daily injections. Then you switched to an insulin pump a few years ago, at first without the CGM, and now you have a pump and CGM that communicate with each other.
Yes, the CGM has made things a lot easier for me to manage.
And how is your glucose control?
It's very good now, but it hasn't always been that way. When I was younger, I wasn't too careful about what I ate. I didn't always take my insulin before each meal, and I hated finger sticking.
So what changed?
Well, for one thing, once when I was 17, I ended up in the hospital with diabetic ketoacidosis. I was in ICU for a few days. I could have died.
Wow, how did you get so out of control?
I was a senior in high school. I had stopped finger stick testing for a few days, and I might have missed some insulin shots. It was before I was on the pump. I started to feel really weak, and I threw up. I finally tested my sugar, and it was over 500. So at the hospital, they gave me fluids and insulin in the vein until I felt better and was able to eat again.
Sounds like that was sort of a wake-up call.
It was. It was right after that that I started using an insulin pump, and that made a big difference for me.
Do you recall what your A1C was at that time?
About 8%.
Okay, so now tell me about your experience using a CGM.
Well, at first I didn't like it because it showed through my clothes. Plus, I'm a yoga instructor, and I was worried that it was going to fall off during class.
Okay, then technology improved a few years ago so that your insulin pump could be integrated with the CGM, and I suggested that you try the CGM again.
You did.
And how is your A1C now?
It's been ranging 6.5% to 6.9% over the past year.
Great. And why did you agree to continue with the CGM?
The integration definitely makes life easier. I see the readings and the arrows on my smartphone. I don't worry as much about going low, so I make sure to take the right amount of insulin before each meal. And I know the CGM will alert me if my sugar is going too high and not coming down, so I can take care of it. I know I won't end up in the hospital again.
That's great. So let's look at your CGM blood glucose chart.
Okay.
Your glucose seems to rise every day between 4 and 6 a.m., but your sugars look really good during the day.
That's the dawn phenomenon?
That's correct. We would not have seen this if we only had finger sticks to look at. So we'll raise your basal insulin by adjusting the settings on your pump by 0.2 units an hour from 3 to 6 a.m., and we'll keep monitoring.
Sounds good.
Now let's meet Barry. Hi, Barry. Welcome.
Hi, Dr. Brett. How you doing?
It's nice to see you. How's retirement going?
So far, it's great. Bit of an adjustment, but I'm filling the time, keeping in shape.
Retirement's a great time to revisit your health goals. You'll enjoy retirement more if you're feeling good. And you were able to retire early, weren't you?
Well, not that early. I am 62 years old, but I'm happy to have more time to focus on my health. I've had diabetes for about 10 years now.
What type of diabetes do you have?
Well, I was originally diagnosed with type 2, and later we realized it was type 1.
When you were first diagnosed with diabetes, your A1C was around 6.8, and you were managed with diet and exercise alone. Then you were referred to my practice when your primary care physician found that your A1C had jumped to 10.4%.
Right.
I recall that you didn't seem to be a typical type 2. Neither of your parents had diabetes, and you were pretty thin. So I checked your glutamic acid decarboxylase, or GAD antibodies, and found they were positive. So we called it LADA, late onset autoimmune diabetes of adulthood.
Exactly.
Do you recall what was your initial treatment regimen?
I started taking a small dose of insulin detramer and metformin.
That's right. And then we added linagliptin to your regimen, and that worked well for about 5 years.
Yes. My primary care doctor was monitoring my treatment, and I felt good.
Were you testing your blood glucose with finger sticks then?
Yes, I did a finger stick test in the mornings and whenever I didn't feel well. My blood glucose never went above 160.
And your A1C was good?
Yes, it was always under 7.
And then what happened?
Well, and then this year my sugar started spiking. I started to not feel well after breakfast, and I checked my sugar and it was over 300. All I had was Cheerios, and every day it would go up.
Yes, and that's when you called me. And the first thing we did was to try to change what you ate for breakfast, but it didn't seem to make a difference.
Correct. No matter what I ate, even if it was eggs and toast, my blood glucose was quite high.
And that's when you started using the CGM so you could monitor your blood glucose more frequently before and after meals. Let's see what those spikes look like. As you can see here, every day after breakfast, your blood sugar spiked to between 2 and 300. At that point, we stopped the linagliptin and started a rapid-acting insulin injection before breakfast.
Yes. The CGM charts really helped me to see where my glucose was whenever I wanted to check it. You know, you can get kind of obsessed with it, seeing how your body responds to different foods.
So when you first started using the rapid-acting insulin, we were in touch pretty regularly. And then the pandemic hit and you moved out of the city. We could still review your glucose charts together because you were able to upload your CGM data and connect to my clinic. I could review your blood glucose charts remotely during our virtual appointments.
Absolutely. It was easy. Then during our appointment, we looked at the data together. We used the data to help us figure out what I should eat. We talked about the carbohydrates I was eating, and we figured out an insulin to carbohydrate ratio that I could use so I could have more flexibility in my meal choices.
Since then, we've made a few adjustments. I think now you're taking 1 unit of insulin for every 10 grams of carbohydrate you're eating, and you're using an insulin sensitivity factor of 1 to 40.
Yes. At first, I only needed the insulin injection with breakfast, and now I need it with each meal.
And your last A1C was 6.3%, so you're making great progress.
Yeah, and maybe too good. I recently had a bad low glucose episode after playing tennis.
I recall that. Tell us what happened.
Well, I'd eaten lunch and taken my insulin as usual, so I thought I'd be okay. Then after the match, I felt hungry again, and I was really irritable. Luckily, the CGM alarm warned me that it was low blood sugar. I took a full glass of juice, and the arrows were still going down. I rested and took another glass of juice. It was a good half hour or so before I started to feel better.
Well, I think you're learning a lot about your diabetes management by using the CGM.
Oh, I totally agree with that. I'm glad that I decided to try it. I feel confident that I'll be able to have a great retirement and still be able to do everything I want to do.
Now, a discussion with primary care physician Dr. Kimberly Wen and Dr. Elise Brett about continuous glucose monitor utilization.
Hi, Dr. Wen.
Hi, Dr. Brett.
You're a primary care physician. You must see a lot of diabetes patients. Do you have experience using CGM in your patient population?
Unfortunately, not as of yet. My patient population is mostly kind of geriatric in age and mostly type 2 diabetics. We do have the ability to start, considering CGM as a modality for management of diabetes, but I think one of my biggest challenges is to try to figure out what would be the appropriate patient population. So do you have any tips for me in terms of, what criteria would be an appropriate patient population?
I think CGMs can be appropriate for any patient with diabetes who is motivated to improve their glycemic control and improve their time in range. Certainly, the devices are most appropriate for patients who are using agents such as insulin or sulfonylureas that increase their risk for hypoglycemic reactions. But really, they can provide important feedback for any patient with diabetes who can use the information to see how exercise or certain foods and their medications have an effect on their blood sugar, and use that information to improve their overall glycemic control and monitor their blood sugar more often than they would typically be able to using regular finger sticks.
Yes, and speaking of the hypoglycemia unawareness, I feel that in particular with Susan's case, I have definitely a handful of patients who might actually fit into that category. So my question to you would be, how do you go about figuring out which patient would be appropriate to use for CGM if they are having hypoglycemia unawareness?
So it's always difficult to figure out who's having hypoglycemia unawareness. I think there were several clues in Susan's case. Susan had progressively lost weight, and her insulin regimen had remained unchanged. Her morning glucoses were on the low end of normal, and her hemoglobin A1C had progressively declined so that her A1C was very tightly controlled. And although she wasn't having any symptoms, those were hints that perhaps she was having overnight hypoglycemia. And then it was very obvious the first time that she did agree to wear the CGM that was the case. And we were lucky to have detected that before she got into any trouble.
Definitely. And moving forward with this, in terms of trying to figure out how to integrate this into my practice, I do wonder, what is the workflow like for you in terms of monitoring CGM? Are you getting reports every 1 week, every 2 weeks? How does that work for you?
The majority of my patients wear the CGMs at home. Some of them use them on a regular basis. Some of them use them intermittently. And they use that data to provide feedback for themselves to adjust their daily habits. Some of them contact me from home to review their data remotely, either by phone or via video visit. But the majority of patients will come into my clinic and we will download their devices during the regular visit and go over the data together and adjust their treatment regimens while they're in the office.
And what does the typical CGM report look like?
Different CGM devices utilize different software, but there are certain features that are common to the reports. Each of the CGM reports provides a time in range, which is one of the most critical features to the report. So we generally target, for most patients, we want to target a 70% time in range. And then we look at time above range and time below range. And typically we want to see a less than 4% time below range and less than 25% time above range for the majority of patients, although those targets will vary depending upon the patient. We also look at an average glucose, and most of the reports will also provide something called a GMI, or glucose management indicator, which is similar to an estimated hemoglobin A1C. And then most will also provide something called glycemic variability, or coefficient of variation, which is an estimate of the degree to which glucose fluctuates during the day, which also provides very helpful information. And then they will also provide daily graphs, which show different individual days, which helps you identify patterns in glucose trends. So you can tell whether the patient's having overnight hypoglycemia or postprandial hypoglycemia. It allows you to identify specific trends that help you to adjust the treatment regimen.
Wow, that is actually a lot of information available at your fingertips. In my practice, especially with this last year during the pandemic, obviously a lot of my appointments have been virtual. And I just wonder how it's like for you, managing your patients with CGM virtually during this pandemic that we've had last year.
I've found the CGM devices to be particularly helpful during this past year, especially when there have been many patients who have been unwilling or unable to come into the office. It's allowed me to connect with them through virtual visits, and especially when many patients have been unable to get to a lab to have the hemoglobin A1C tested, to be able to have this data available from the CGM reports. It can be even more helpful than the hemoglobin A1C. And I've been able to help them to adjust their treatment regimens and stay out of trouble and avoid the extremes of hyperglycemia and hypoglycemia.
Well, that sounds wonderful. In thinking about moving forward as well in my practice, what can you tell me about what you oftentimes hear as patients' concerns about starting CGM?
Patients sometimes do have concerns about starting to use a CGM device. Sometimes they may have concerns about being able to insert the device themselves, which is actually quite simple. And usually once they've done it themselves, they're able to continue to do it on a regular basis. And often we'll do it the first time together in the office. Sometimes patients have concerns about the device showing through clothing, but the devices continue to get smaller and flatter. And usually once patients get used to it, this becomes much less of a concern. Sometimes they're concerned about the devices falling off, and this happens occasionally, but they are easily replaced. And sometimes there are concerns about cost, but the insurance coverage for the devices continues to get better and better, and the price for these devices continues to go down.
Do patients wear it in the shower?
They actually do, and most of the time they don't fall off.
Well, that's good to hear. Well, thank you, Dr. Brett. You've answered a lot of my questions, and I do look forward to learning more about this and hopefully utilizing it in my practice.
I think these are wonderful devices, and overall, for most patients who use them, they've been able to decrease the risk of low blood sugar reactions, improve their overall glycemic control, time and range, and improve their overall quality of life. So the more that we can use them in both type 1 and type 2 diabetes patients, the more that we can improve quality of life for people with diabetes.
Sounds great.
Thank you for participating in this educational activity. In my practice, I see more and more patients benefiting from the use of these CGM devices. Prescribing of these devices does not have to be restricted to endocrinologists. During this activity, we showed you the different devices, how to select patients that are appropriate for use of these devices, and the benefit that your patients can get from real-time use, as well as the data that you can obtain from the downloaded reports.
Thank you for viewing this program. This concludes the educational activity. To earn credit, please click the link below to access the post-test and evaluation.